When you're rolled into an operating room today, you assume every step is tracked. But for most of medical history, you relied on unverified reputation. Surgeons operated, patients lived or died, and the results were rarely scrutinized by anyone outside that room. Early 20th century hospitals had every incentive to keep things opaque. Publishing failure rates invited legal exposure and threatened the prestige of senior colleagues. A surgeon's skill was treated as a matter of individual judgment rather than a measurable, comparable outcome. In 1914, that opacity collided with a Boston surgeon named Ernest Codman. He was pushed out of Massachusetts General Hospital for a practice that sounds unremarkable today, tracking his patients after surgery and publishing his failures alongside his successes. Systemic medical accountability did not begin as a standard hospital policy. It began as a resisted rebellion against a profession that preferred to leave its mistakes unrecorded. Codman called his idea the end result system. When his colleagues dismissed him, he opened his own small hospital in 1911 specifically to track outcomes. He categorized every surgical complication and published the findings for anyone to see. By 1916, Codman's data showed 123 documented errors across 337 patients. He mailed these results to hospitals nationwide and even unveiled a cartoon mocking the profession's unwillingness to confront its own failure rates, a move that saw him effectively ostracized by his peers. Codman died in 1940 and was buried in an unmarked grave. It took until 1996 for the Joint Commission, the organization he helped start, to create an award in his honor. The medical profession spent most of the 20th century resisting the quantification of its own harm, making a future national reckoning over the numbers inevitable. In 1999, a report estimated up to 98,000 annual U.S. deaths from preventable errors. By 2016, a separate team pushed that estimate over 250,000 deaths. But these massive estimates remain fiercely debated. Extrapolating state-level samples to a national toll often stretches data further than underlying studies support. While the debate over historical numbers continued, Dr. Atul Gawande shifted the focus toward a fix. In 2008, he led a WHO initiative to pilot a 19-item surgical checklist, a simple tool covering basics like blood loss risk and equipment checks, to be confirmed aloud by the surgical team. The results across 8 diverse global hospitals were dramatic. Major complications fell from 11% to 7% of patients, and inpatient deaths were cut nearly in half, holding steady in both the wealthiest and poorest hospitals in the trial. Surgical error is a stubborn systemic problem, but precise measurement proves that a significant share of that harm can be engineered away with simple, rigorous protocols. To understand the actual stakes, we have to look at how post-operative death is defined. A 2019 analysis in The Lancet estimated that at least 4.2 million people die worldwide within 30 days of surgery every year. But those deaths are overwhelmingly driven by the severity of the disease that required surgery in the first place, things like ruptured aneurysms or advanced trauma, rather than a preventable mistake made during the procedure itself. Genuine never events, like operating on the wrong body part, are tracked separately because they should not happen under any circumstance. In well-tracked health systems, these specific errors occur on the order of 1 in every 100,000 or more procedures. When the unavoidable physiological stress of a severe illness is counted as a preventable mistake, the resulting data misrepresents the actual source of risk for most surgical patients. Any discussion of surgical harm has to be weighed against the enormous scale of the treatment. An estimated 313 million surgical procedures are performed worldwide every year. Of those procedures, only 6% occur in the world's poorest countries. The Lancet Commission found that this gap in access is the single largest driver of preventable surgical death worldwide. Scaling up basic surgical access in low- and middle-income countries would prevent an estimated 1.4 million deaths every year. That number is 5 times higher than even the most contested estimates of annual medical error deaths in the U.S. At a global scale, the total absence of surgical care takes far more lives than a breakdown in surgical technique. The data provides a clear answer. The mortality prevented by surgery every year is several orders of magnitude larger than the harm caused by medical error. When you enter a modern operating room, the trust you place in the team is validated by a century of hard-won data. That structured, cooperative environment is the direct result of a profession finally learning to look honestly at its own failures. The goal today is no longer questioning if surgery is worth the risk, but committing to the unglamorous, sustained work of engineering away the tiny fraction of harm that remains.